afternoon.
Good
We are
afternoon.
so excited to be here today for the State of Black Health webinar series, really all day. BlackDoctor.org is doing this all afternoon. We are the breast cancer segment, and we're going to be talking about breakthroughs in breast cancer. And I'm not sure if there's a lot of breakthroughs, but we're going to give as much information as we have as we need. And I have this amazing panel of these beautiful, brilliant Black women. And I love our Black women so much. And so I think we're hopefully going to bring you some insights and you'll learn a little bit and get informed about what we call Black breast cancer. So, you know, I'm the CEO and co-founder of Touch the Black Breast Cancer Alliance, and we actually have our own definition for Black breast cancer. We believe Black breast cancer is a different disease, needs different different treatment and really different attention. And I'm going to read this definition to you, okay? Because we believe this is what it stands for. It's the constellation of exposures, experiences, and lack of science for Black women diagnosed with breast cancer that causes Black women to face disproportionately worse breast cancer outcomes. And I'm just going to talk a little bit and give you some stats, and then I'll introduce our fabulous panel. But, you know, Black women, the latest data came out from the American Cancer Society last week. We have a 41% higher mortality rate than white women. Black women under 35 get breast cancer at twice the rate, die at 3 times the rate. Black women like me, I'm a 10-year survivor of triple negative breast cancer. We have a 71% higher risk of death. Black women who've had breast cancer have a 39% higher rate of recurrence. These numbers are just crazy, right? And we have to do something about it. Black women are 3 times more likely to get triple negative breast cancer, which has the highest mortality rate and the worst outcomes. We're getting breast cancer at younger ages, and we are dying in too big of numbers. And so we have a lot of work to do. And we believe a lot of it has to do clearly from the social determinants of health. And they're there. But we also believe it's scientific and biological and possibly genetic. And we don't have enough science to really understand that. So we're all about trying to figure out how we can bring more science to this disease and just better care, better resources, better treatments. And so this panel is just a bunch of amazing women and doctors that are going to kind of share their stories and what the work that they're doing in the community. And we're so excited here to be with you. So I'm going to let my panel introduce themselves. I'll start with our amazing patient advocate, Lakia.
Hi, good afternoon. Thank you for having me. My name is Lakia Belcher. I am recently just turned 40 in December. I am a woman thriving with metastatic breast cancer, and I have made it my mission to educate my sisters in the cloth and make sure that we eradicate breast cancer for women, but Black women especially.
Great. And Reverend Tammy.
Hi, and thank you, Ricky. You're amazing. It's awesome to be here. I am a 17-year breast cancer warrior. I am the co-founder of Carrie's Touch, a breast cancer organization whose target is to save more Black women. And I'm the co-founder of Project SOAR, Speaking Our African American Realities, a research collaborative with UCLA, studying the strong Black woman and breast cancer.
Cool. Dr. Gigi.
Good afternoon, everybody. I am the founding director of the Rodham Institute, which is dedicated to health equity, but I am also a 15-year breast cancer survivor. And actually last year I had kidney cancer as well, but I'm fine. I would like to bring the lens of how medical apartheid has caused deaths of Black women in breast cancer, and how when a Black woman finds a lump, gets her mammogram, and gets treatment, there are usually delays of at least 6 months greater than her white counterpart. And we know that time is life.
Yes.
The delay in diagnosis and treatment means your life. I'm honored to be on with you this afternoon.
Thank you. And Dr. Kendra.
Hi, I'm Dr. Kendra Outler. I am a staff anesthesiologist at Walter Reed National Military Medical Center. So I come to you as the person in between a patient and the surgeon that I interface with both. So I learn a lot about both sides in terms of patient advocacy, understanding what my patient needs, and getting them back to their families is one of my biggest goals. I think that I also developed Uzima Health and Wellness to continue to talk about health disparity in this whirlwind of COVID. We see that we still have a lot of issues, particularly breast cancer disparity, that we need to discuss. So I'm happy to be a part of the panel.
Great. And my precious partner in crime, you know, we are the co-hosts of The Doctor Is In, and my bestie sister, lover to death, Dr. Mo.
Well, that was my introduction. I'm Dr. Mo. I am a breast surgical oncologist, so fellowship trained in breast cancer surgery, and I'm the medical director of the cancer program at Grandview Health in Sellersville, Pennsylvania. We're one of the Penn Cancer Network hospitals. I'm also co-host of The Doctor's In right here on blackdoctor.org every Wednesday night at 6 p.m. Eastern Time. I am an advocate. I am on the medical advisory board for Touch, for Tiger Lily, for Living Beyond Breast Cancer, and I really view my role in this journey of breast cancer, particularly as a bridge and as a healer in the gap between our communities and our medical establishment. I think that there need to be more of us willing to do this sort of healing work and reimagining what equity can look like. And so I'm definitely a willing participant in that. And I spend all my extra time working on those things. And I am just honored to be on this panel and talking about these subjects and on today of all days. So thank you for having me, and let's do it.
Let's do it. Let's do it. And you know, I thought we would start with our baby Lakia story. And you know, I always say that there's a lot of lives attached to a tumor. Not just the body that it's in, but there are a lot of lives attached to this tumor. And you know, the mom, you know, you tell the story. Let Lakia tell her story, because I think that people need to hear what breast cancer looks like, what Black breast cancer looks like. And you know, we've got, you know, our other stars, but what does it look like, Lakia, to you? You know, you're just turned 40.
Just turned 40. You know what? For me, and I'll go right back to what Dr. Gigi said, it took a while before I was actually diagnosed. I found the lump thanks to my god sister, who was a triple negative warrior, that ultimately, you know, lost her fight to breast cancer. But she would send out reminders, check your breast once a month. And I became very, very familiar with what my breasts looked and felt like. And in June of my 38th year on this earth, I found a lump. And I went and saw my gynecologist. She recommended an ultrasound and a mammogram. And that radiologist told me that it was scar tissue from a previous surgery. But I knew in my gut that that wasn't right. And then 3 months later, my lump had grown, sent right back to that cycle. That person, that radiologist said, nope, it's still breast cancer, and said she needs to wait 6 months before she comes back. Then I was referred to a breast surgeon, Dr. Quarterman, who understood how I was feeling, understood that I needed answers. As a mom of 2 young children, I have a 9-year-old and a 6-year-old. I have a loving husband. I work full-time as an educator, and it was devastating to me that I just kept being told no, that nothing's wrong with me. But I knew that something wasn't right. And God bless Dr. Quarterman for being willing to step out there and say, you know what, since your insurance is not going to cover it, let's do an in-house biopsy. Let's get to the bottom of this. And that's the only sure factor. Well, lo and behold, months later, we went from June to October. In October, I finally got answers. It was breast cancer. I was relieved and then devastated all in the same phone call. But grateful that I had a Black doctor willing to put her money where her mouth was and to help me find answers. And then from there, you know, you do the roller coaster ride of more testing. Now insurance is on board, right? She has cancer. We got to do everything we need to do. So I, you know, ran down the gamut of testing and poking and prodding. And ultimately what was determined is that I had metastatic breast cancer at 38 years old. And what a blow that was to my system, to my husband, to look at my children and to hear the morbidity of metastatic cancer, meaning I had breast cancer that had traveled outside of the breast and had set up shop and ultimately the top half of my body. And then it was like, okay, let's talk about treatment. But before I had a conversation with my oncologist about treatment, I explained to her very clearly, I'm a wife, I'm a mother, and whatever you decide to do affects my whole family. And you are now going to be a part of my family. And if we can't have a relationship where You understand the full circle that is Lakia. I'm not just a patient number. I'm a person. I'm a human that's going to deal with whatever we decide as treatment. Then you're not the right doctor for me. And she was understanding, and I was very clear. I'm the most important person in this room. It is my life that we're dealing with. And now, almost a year and a half later, I advocate for other women. I talk to other women about how to make sure that they're not just going with whatever the good doctor tells them, that they push back, they ask questions, they bring other people to the table to help them kind of digest everything that is going on. And I'll tell you, being a part of Touch and working with Unite for Her has made all the difference. Helping other women is a part of my healing. Making sure my 4 younger sisters and my daughter, understand and have conversations and know their bodies well enough when something's not right, and to feel strong enough and empowered to push back on, no, that's not what you think it is, or no, the radiologist said this. No, I need answers. Then I need everybody else in my circle and everyone else I touch to understand that you're your first best advocate. You know your body better than anybody else. So speak up. There's no timidness when it comes to health. There's no timidness when it comes to Black cancer. And there's no timidness as a wife and a mother dealing with metastatic cancer. So here I am. I'm going to yell it from the mountaintops. I'm going to make sure that people that come behind me, and that even some women that are before me and just went with the status quo, that is not acceptable. We're not a mediocre people. So why do we let our care be mediocre? And I'll stop there because I can go on for hours.
All right, pick it up, Dr. Tammy, Reverend Tammy, pick it up.
Oh, wow. Well, I could have listened for hours because I'm hearing myself and my story as well. And I think a thing to note in this conversation is that persons like Lakia and persons like myself and you, Ricky, we're anomalies. We are women that walked in the doctor's office and took charge. But because we've been socialized to not say anything, to not question authority, to not push back on what the doctors tell us, most of our women don't go into the doctor's office with that same empowerment. I remember when I was first diagnosed 17 years ago, shortly after my doctor had told me that 41% Black women die at 41% higher rates than white women. He also offered me an opportunity to participate in a clinical trial. And when I asked him, just completely out of ignorance, I'm a Black woman and I know things happen differently for Black people, but I didn't know anything about breast cancer. But I asked him, I said, how are Black women responding to this trial? And what he said next changed my entire trajectory for my life. He said, I don't know. And I'm like, what do you mean you don't know? Here I am sitting in your office. You just told me I'm diagnosed with breast cancer. You're offering me a treatment option, and you tell me you don't know how it's going to work on women that look like me. And I got angry, and I entered the clinical trial out of anger. I was annoyed. I was frustrated. I was disgusted, and I participated in that clinical trial. But what came next was a 32-page packet of possible side effects. And so then I got wise and I educated myself. I sat down with my researcher and I went through the 32 pages of possible side effects. Now, don't let the 32 pages scare you. If you take Tylenol, there's a whole list of possible side effects for Tylenol. Everything that we put in our bodies that is foreign to our bodies, there's going to be a side effect to it. And for me, 17 years ago, we were in the early stages of this clinical trial and understanding how these medications were going to work just on all women, not just Black women, but all women, looking at the efficacy of these drugs, whether or not they should be administered every 14 days or every 21 days. But I needed to understand for myself what I was signing up for. And I was sick. My family wanted me to stop the trial, but I knew that my life was going to live beyond the projected less than 5 years that my doctor said that I would survive beyond the diagnosis. And so as a result, my late sister and I, we formed Carrie's Touch, that has been advocating for representation in clinical trials, Black women in representation for clinical trials since I was diagnosed 17 years ago. And we are working now trying to understand some psychology behind the decisions that Black women are making, understanding the good and the challenging aspects of the strong Black woman, and how, while we can wear that badge of honor and with pride, in so many instances, it hurts us because we remain silent, and the silence is killing us. So I'll pause there so we can continue the conversation.
And Reverend Tammy, I don't want to give away your age, but you got breast cancer very young too, at 39, right?
39, yeah. Oh, I'm proud of my age, especially
Oh,
with
you're looking hot, Mama. Yeah.
I will be 57 in 1 month.
Yeah, and you're gonna have a grandbaby, which is the best love ever.
Yes. It'll be my second, but my first girl. Yeah.
Yeah, that's great. So I think, and also you didn't mention that you did the clinical trial for Herceptin, and Herceptin was a major breakthrough in breast cancer.
Major breakthrough
and HER2 breast cancer, which was what Herceptin is used for, is very prevalent in the Black community and was very fatal. Very fatal. So you are saving lives. In fact, Dr. Gigi has a story about that. So Dr.
Yes.
Gigi.
So because of your generosity, Reverend Tammy, because of your determination to get more information, I was one of, I'm sure, thousands of beneficiaries. So I said my breast cancer was 15 years ago. It's actually been almost 17. And I was in the midst of a divorce, which I'm sure was related to getting the breast cancer in the first place. And I started the Herceptin. It had just been approved in February, and I started in July. And so your personal sacrifice and your intelligence and your commitment had a direct impact on me. And so when I was diagnosed with kidney cancer, I decided to pay it forward. And now I'm in a clinical trial. It's an observational trial because this kind of information is life-saving. This is not just an abstract. And I would just say that studies show that going to physicians of color and clinicians of color improves outcomes. That's not to say that there aren't lovely and brilliant white physicians, but that's what the statistics show from the National Medical Association, which really looks at this. I also want to say about the part about stress, because I was certainly stressed in the midst of this, all that I went through. Getting divorced, I don't know which was worse, the breast cancer or the divorce. But, when we're thinking about genes, and I know we're going to talk about this a little bit more, my family, actually, there was no family history, but we may have had a predisposition, I don't know, but the interaction of stress and genes, it's a dynamic interaction, so that the stress can actually turn on predisposition. But in the reverse, exercise can actually help to turn off certain genes. So I think, being educated about these things and not feeling that getting cancer is inevitable is key. So thank you. I thank you from the bottom of my heart. You saved my life.
And a lot of others. Thank you, doctors. Divorce is a whole nother episode to talk about, right? But I actually caused my divorce during my breast cancer because I had to learn that my peace is non-negotiable. And I not only had to get the cancer out of my body, but I had to get all the cancers out of my life. And that was part of my treatment plan. Really, not necessarily on purpose, but I think, and we hear so many stories, and Lakia is very blessed to have her adorable husband, Chris, to support her, but that is not always the case. And you can't take that for granted. We have so many women that are, that have difficulty with that. So it's definitely a challenge. Yeah. So Dr. Kendra.
Hi. So I like your slogan that, and you're saying that these tumors are attached to lives. So when I ran my breast cancer campaign for Uzima Health and Wellness, it was developed to focus on the outside person looking in and really observing the loss of a friend, a loved one, a wife, It's that story I felt like was not told enough about how, as a matriarchal society, that when we lose mothers, sisters, girlfriends, godmoms, you name the different roles that Black women take over in a community. When you lose them, it's very painful, and it can change the trajectory of a family. So I took up the cause of breast cancer because I've had 8 friends and counting develop breast cancer. And some of them have lost their battle and fought very bravely. And some of them are still fighting right now. So I call it every day is breast cancer awareness for some of us who have been impacted by this disease. Black breast cancer, or breast cancer that behaves very differently in Black women. And I've had the privilege of being on the front side of taking care of patients, meaning I was a family medicine doctor. And I think very hard about prevention, about our approach to counseling. And I brought that to my second career as an anesthesiologist. And I thought, well, I can still counsel a woman. When I see patients that present, or women that present for breast cancer, sometimes you're met with a lot of denial. Oh, this is going to be okay, or they're very stoic-y. I think that Black patients who feel marginalized by the healthcare community can be very stoic. And you say, do you have any questions? And they say no. And if I have a mask on, I'll take it off. And I think that we need to understand that every part of the healthcare community we have to engage with. We should demand a certain level of respect. And how do you get that? I think that educating people that you have a name. So easy for people to call us sweetie and honey bun or dear. If you tell me my name, then I know that you've looked at my chart. So when I educate patients about being an advocate, it starts with identifying who's taking care of you and telling them to address you by your name. And this is very important. Another thing is that you have the right to have an advocate beside you. Breast cancer is just overwhelming. Any cancer, a major life-changing illness. We know that breast cancer is very common. It's a common surgery. It's one of the first surgeries that a woman could have that introduces her to the healthcare system. So all of a sudden, you've seen a radiologist, you've gotten a biopsy, you're scheduled for another biopsy in the OR. And here comes someone talking to you that may not know who you are. May not know who your allergies are. This points to the issue of getting through the healthcare system as a Black person alive. There are mistakes that can be made when people don't know who you are and never looked at your chart. And unfortunately, given the need to be automated, to be faster in healthcare, these things are missed, Black, white, or any other race. But particularly for Black patients that become disengaged, this could be deadly. Not only you have a deadly disease or you're struggling for your life, now you have a sentinel event, or as we call it. But so I would say to ask 3 questions. What is my surgery? To the anesthesiologist. How are you planning to administer the anesthesia? And why do you think that's the best plan for me and this surgery? We call it the Ask Me 3, whether you're in primary care. These are 3 questions: what, how, and why. And I think that if patients can just empower themselves to ask these 3 questions, no matter who the healthcare provider is, they will at least have taken a step towards engagement. And I think that we have to recognize, even though that Black physicians can feel more comfortable with us, we have to know this. We're only making 6.5% of the workforce, right? So we are engaging with people who may not talk to us unless they have to. So when we speak up and they hear our voice, sometimes you get that look that says, "Why are you talking to me?" But you have every right to talk to them. You have every right to be your advocate. And if you don't feel strong enough, please bring that vocal friend, cousin, into the room and say, "Speak for me," because everybody has different personalities. So when I'm interacting and and we're getting ready to go to sleep and a patient doesn't ask me anything, I then create a safe space to tell them some things. And then they say, I do need to be talking to you. I do need to be engaging with you. And so I would like patients and people and our women who are presenting, please ask 3 questions. please ask them, what are you doing? What is my name? We can start there. How and why? And there are advances with surgical oncology. So we are presenting with patients that may be a little bit sicker after they've had chemotherapy. So it's very important that everyone knows where to put your IV, where to put your blood pressure cuff. Have you met with the surgeon? Have you had your pre-anesthesia evaluation? So that's my preventive and health disparity take on all of this. If there's any intervention I could do.
Thank you so much for that. And you know, we meet so many new patients, right? They call us, okay, and I think they're often surprised by the number of doctors they're going to encounter when they're dealing with breast cancer. So who knew you're going to have a surgeon and a radiologist and a psychologist and an anesthesiologist, like all these doctors, and they don't even know. They have their understanding of just going to the doctor is so limited and often so
it's overwhelming.
It's overwhelming. It's all new and like who are all these people? What are they really going to do for me and my body, right?
And we have to also remember that we also have paraprofessionals, because I know Dr. Monique probably has to, rely on a nurse practitioner at times. So everybody on your care team needs to identify their role.
Right.
I've even had to say, who is ultimately responsible for my care? If you're in a teaching hospital, it's not the resident. It is not the intern. If you are in a private hospital, it's not the paraprofessional. It is the physician of record.
Right, for sure. And so that's all. So it's great learning for us.
Wait, Ricky, can I jump in here real quick as a patient? Because I think the other part that's important that we ask is, if you're not available, who is next in line to help take care of me? My doctor, oncologist, went out on maternity leave. So very grateful that she had a nice, healthy baby boy, but who's going to take care of me while you're out? And I need them to have the same understanding that you have, and I need you to brief them before they get into my room. Because if this is not going to work out, we're going to have to do something else. But I think, again, it goes back to women feeling empowered to push against the authority that are the doctors in order to get the answers that they need. But who's a substitute? Who's checking in when my doctor checks out?
Right.
And are they familiar with my plan? Are they familiar with the expectations that I have, that we have together in order to continue my same level of care? Because I don't want a sub coming in and give me subpar because my actual doctor is out. And I need that same level of support, same level of care, same answers to my questions as if you were my primary doctor. And again, it goes back to educating, feeling empowered, and finding the right supports in order to say, this is what I need. And if y'all can't get it right, there's other doctors. There may not be other Black doctors, but there's other doctors.
It's hard though. I'm gonna jump in here and
introduce you first, because I want to say something before you talk. All right. I'm sorry.
No,
but so to me, Dr. Mo helped me define what I believe is health equity. And health equity is when your doctor treats you like their family. And I've watched her say to patients, don't worry, I've got you, because I'm going to treat you like my sister. I'm going to treat you like how I would treat my mother. I'm going to treat you how I'm going to treat someone that I love. And that is the kind of care that defines what we should all be privy to, right, and have access to. So now you can talk.
Thank you. And it extends beyond just the care that you provide. Like if I reach the limits of my knowledge, I encourage my patients where to go elsewhere for resources. I ask them what they believe. We spend a lot of time talking about what it is that they understand, because health literacy in our community it's already questionable. It's low. It's a lot of things that have been passed down and misinformation. And at a time when you are diagnosed with this disease, you don't have an awful lot of time to be doing a whole lot of research. And so it is difficult for patients, I think, to navigate this system. I remember, being 7 years old, my mother died of ovarian cancer. She was 29 years old, and she died of this horrible disease that nobody talked about. And then my grandmother took us in and raised us, and she got diagnosed with breast cancer the first time when I was 10 years old. And she went to the doctor, and this doctor said to her, well, maybe you got 6 months left, maybe a year, maybe you start making some plans, and for what your arrangements and things are going to be. And I remember that she said, well, no, I can't do that. I have these 2 girls I have to raise, and one was supposed to be a doctor, so there's no time for the dying. So what else do you have for me? Right. And then 7 years later, she got diagnosed with breast cancer in the other breast, and she went to another doctor who told her again, well, maybe 6 months left to live and start making your arrangements. And she said, no, you don't understand how this works. But I remember her and my grandfather feeling very confused, very lost in how to navigate this system. And she lived another 25 years and died of heart failure, and in her late 80s, because she took the opportunity to educate herself. I watched her go from fear to confidence, and it was an example for me, even as a physician. And what I know is that, if Black Lives Matter, right? If we are now in this, the beauty of 2022 is that everybody is shouting from the rooftop about what the worth of our lives and our stories and our lived experience is. It matters. Our biology matters. And I think that too often we are brushed aside and put into this category of the social determinants of health, which certainly impacts our outcomes. But when you look at Black breast cancer, when you look at the rates of what we call basal cell or triple negative breast cancers, HER2 positive breast cancers, we are more likely to develop those. And whether or not it's a result of changes in the genes and the gene expression as a result of, stress and things like Dr. Gigi talked about, absolutely entirely possible. Whether it's a result of changes in the genes themselves that we were born with and the heredity, absolutely possible. We know that ancestry matters, and we are just now at the point of even understanding that the tests that we've been using on European white women actually work on Black women. That's the data. That's the hot topic in the press. It's like, oh, the test works. Right. In 2022, year of our Lord, we got a lot of work to do. Our representation does matter. Lakia, there's 2, maybe 3 Black female breast cancer surgeons in the state of Pennsylvania. And so if I'm out, guess what? And I need the question that patients want to ask looks like, who would you go to? Where would you get your care, doctor? Right? That's the highest recommendation that one can provide, and making sure that we offer those services, offer that second opinion. It's not an indictment against our quality of care for a patient to go somewhere else and hear what they need to hear and feel the relationship that they need to feel, because it is an ongoing relationship. Like Dr. K said, this thing is it's not one and done. Patients have to feel seen, and they need to feel partnered with, so our biology matters, our representation matters, and what we believe, our worldview about our health needs to matter more. I've heard 3 times already where we start to talk about stress, about nutrition, about just what our faith, right? And all of those things need to be considered by our clinicians in a very short amount of time. And so making sure that the patients who are watching, the advocates who are watching, that you're asking those questions. You're looking for that doctor that says, okay, let's talk about nutrition. Have we talked about stress? Are you eating good food? Are you getting good rest? What are the barriers to better health for you? Not just your tumor. I'm going to do a surgery. I'm going to take your tumor out. I do a patient no service to remove their cancer if we haven't addressed all the other factors in their life that has contributed to the cancer they have. And so it has to be this 360 perspective that is slow coming in healthcare, but I think that we can lead that charge and we can be that change. And part of the education of our community has to do with asking our doctors that and holding them accountable for those answers. Just like Dr. K said, I thought that was beautifully stated. We want patients to know that we see them. I want them to see me. And I want them to see that I treat them like I treat myself, like I treat my sister, like I treat my auntie or my mother, because that trust has been broken and we have to really forge a new way forward.
Right. And demand it of other doctors, especially white males, that they're out there. So I think that we've mentioned triple negative breast cancer a few times. We should try to define that. That's what I had. It wasn't really fun. I don't, the Breasty Club is not one you want to be in, but once you're in it, we have unconditional love. But Mo, will you kind of give like your definition of triple negative? Because it is, I think the one thing about it that makes, I think, us triple negative survivors special is we're the only breast cancer subtype, of which there are many subtypes, that does not have a drug to prevent recurrence.
Sure.
So I've taken something for 5 years. I don't have that drug.
And it really speaks to the biology of the tumor and what are the targets for therapy. So when we, the one thing I'll explain to patients, when we talk about an invasive breast cancer, we don't know the difference between invasive and metastatic. We hear something is invading, we're thinking, okay, it's spreading, it's everywhere. But invasive breast cancer means that it has broken out of the place where it started. And the easiest explanation I use is a can of Pillsbury biscuits. When the can pops and the dough pops out, now it has broken through, and there's the possibility that it could go elsewhere. When we do a biopsy of that tumor and we look at those cancer cells under the microscope, and we're looking for stations on top of that tumor, very much like, I'm from Pennsylvania, so I'll say the PA Turnpike. I'm looking for toll booths, because if there are toll booths, then I know that you're using dollars. And dollars would be estrogen, for example. And so the targets for cancer therapy have to do with the receptors or the stations on top of that cancer cell. When there's one for estrogen, we can offer a woman a pill to block her estrogen so she doesn't make new cancers grow. If you don't have those stations, then giving you a pill to block your estrogen or taking away your dollars would not be helpful. You're in the easy pass lane. You're not using dollars. And those are women who have to get things like chemotherapy. They're triple negative. There are 3 stations for estrogen, progesterone, another female hormone, and HER2. When those 3 things are absent, those cancers tend to be more aggressive because you're in the fast lane, and the treatments are less targeted because we don't know what drives those cancers to grow yet. And so there's a lot of research that still needs to be done to understand how to treat that for all women, but in particular, why Black women get it more often and get it earlier and get it more aggressive. And it's not related to things like the BRCA mutations, because our incidence of BRCA mutations would be the same. Our rate of BRCA mutations are the same as white women. And so it's not because of a hereditary mutation that we know of, but there's something about this aggressive subtype that affects us more. And so there is work to be done in the biology spectrum.
Yeah, we need more science. We really, really need more science.
More education.
And more education.
As a patient, the only reason why I understood what Dr. Mo was saying is because I've heard it. I've had to go investigate. But most folks, right, most Black women that come into a space with a very educated, highly motivated doctor doesn't understand what the doctor is saying, because so many times we don't have that level of education. I've even had to say, look, I'm a 2-degree person. Can you speak plain English? Like, speak to me like I didn't go to medical school, because I don't know what you're talking about. And it sounds like it might be good stuff, but it's over my head. And, as strong Black women, we don't ever want to admit when we don't know something or we're unclear about something, but I'd be damned. That is how you get the right answers, is to challenge what you heard. Please don't throw a lot of alphabet soup at me, because I didn't read that 800-page medical book. I need you to speak plain English like I'm 3 years old and I'm here, but I need it to be clear. Make it make sense. And so many times we sit back, we take it in, and we leave, and we're pissed because we have no idea what just happened. We just know that here's the next appointment and here's what they're about to do to me, instead of being a part of the plan, being a part of the options, speaking and saying, no, I don't think I want to do that, because that's going to put me down for X, Y, and Z. But we just don't do it. We will go out and fight at a restaurant, right? When our steak is not done well, when our food is not done right, we will throw a fit. But you get in a doctor's office and you act like a timid little baby because you just don't know. You don't feel empowered. We have to change that. The education that needs to be done for our culture, for our women, in order for them to feel empowered, is the key for me that I think is missing. We don't know enough, so we don't ask enough. And we have to find a better way to make sure that we're getting the best care possible.
Right. Dr. Kendra brought something up earlier when we were talking before the session about how a lot of even the time a doctor can spend with you is dictated by their hospital that they're working in. And we did this recent study, and we found that, I believe the number was 65% of breast cancer patients walk away from the doctor's office not feeling equipped with the information they need.
Yeah, I think
that's probably even lower than it should be, because they don't even know what they don't know.
Yeah, I think that we consider, and talk about the messaging for campaigns for breast cancer awareness. We are moving into a different phase now, where we just said breast cancer, be aware of breast cancer. 1 in 9 women can get breast cancer over their lifetime. Now we're beginning to kind of fine tune that message and talk about genetics and the possibilities that happen once you have identified the genetics. That is where cancer treatment is going, that we can identify down to the gene and then begin to target the cells that are growing in a person's body. And that's important, and important messaging to get out to Black communities. This means that when you are embracing a challenge like cancer, breast cancer, that you ask the second question, okay, I have breast cancer. Okay, what type? Now, the third question is, what treatment centers can help me the best? And that is important, because whether you are in Alabama, you need to identify your cancer center. whether you're in New York or DC. We have lots of places in DC. You can go to Hopkins, you can go to GW, you can go to, Georgetown, and you will encounter a cancer treatment center. You may only have one cancer treatment center, major cancer treatment center, that can give you all of your options or enroll you in a clinical treatment center if you are in, let's say, Jackson, Mississippi, or your referral area in Oklahoma. I don't know, but it's important that we identify cancer regions and cancer centers for patients, Black people all over the United States, whether you're in California, and what King Drew versus Stanford versus UCLA is doing, and look at their outcomes. And because that's when the health disparity also can be highlighted. If your surgeon or the outcomes for women are having more infections, or you are not offered certain pain regimens after your surgeries, these point to disparities. These are recorded, and you can find that information and you can ask for that information. So it's all about engagement, engagement, and engagement.
Yeah,
I want to bring up Howard University, because they do actually have a wonderful breast cancer program and a fantastic breast oncology surgeon there. And so
we love Dr. Lori.
Right. And so in Washington, D.C., that's what I would recommend.
Okay.
Even though I'm from GW.
You're from GW, but we have, and we try to help with people. If you call us, and I'll give you our information at the end, we will try to help you find a doctor. You don't feel, and if you're in an area, and I know that Reverend Tammy does the same thing, that if you need help with that, we will try to help you find a Black doctor, a Black woman doctor. So we try to, we call them all the time up at 4 a.m. I need whatever.
There's a wonderful Latino chief of breast surgery at Georgetown now, where I did my fellowship. It is a good friend and a colleague of mine at Georgetown now also. So there are women of color leading the programs all throughout the region. But I think you're right, Dr. K, in that, we need to go where the expertise is. We need to go where the opportunities for research and where things like clinical trials are mentioned on the front end and not the back end, right, as the last resort, where every option is available. Because what we find in healthcare are that the gaps exist because of the paternalistic nature of certain providers for certain services. When we look at why Black and brown women are not offered, why they don't do chemotherapy or more aggressive therapies more often. One, it has to do with certainly what we believe about those medications as toxins. But two, we know that when a physician spends more time, 10 more minutes in that room, or even just explains things better to a patient. There's a study that came out of Boston, out of Dana-Farber, that says when doctors explain things better and spend a little more time, there's 23% more likelihood that a woman would do a more aggressive therapy because she understands it better, because she feels partnered with. Right. And so that matters. It's huge.
Dr. Mo, you hit the nail. Oh, sorry.
Go ahead,
I was going to say, Dr. Mo, you hit the nail right on the head, because even though I was proactive in my personal journey, it wasn't until I understood what was happening. And while it was 32 pages of possible side effects, what I learned is, like, on the first page was the most likely, and then the next 30, pages was really just things that happened to maybe 1% or 0.5% of participants in that trial, but they have to record that. But because I understood what was happening, that made all the difference. And the thing that I want to add to this conversation is, one of the things we promote in Cary's Touch is building healthy patient-physician relationships. And I love what both you and Dr. K are offering to this conversation as willing physicians to have this conversation and to open up the space, a safe space for patients to have the conversation. But that's not our reality for most of our women, right? And even with these wonderful options that we are discussing, for treatment protocols, Dr. K alluded to this earlier, that insurance really dictates where a patient can be seen. We helped a patient navigate from Southern California, transitioning from Southern California to Northern California. And Southern Cal, when they found out that her support system was in Northern California, they released this patient without even placing her. And she had so many problems trying to get connected. And, we called personal Black physicians like yourself at multiple cancer centers. And so I just don't want this conversation to happen as if these are not some of the barriers that keep that 41% alive with the disparity in mortality rates. Because, for me, I'm like, you mean to tell me in 17 years the needle hasn't moved? What are we doing to close those gaps, to minimize and lessen those disparities? And I want those conversations, what you all are saying is key to help shift the narrative, to shift, how we are approaching this. And if we can collaborate, as physicians, patient advocates, and patients, I think we're going to have a better opportunity to save more lives of Black women, because it's not moving fast enough. And 17 years without the needle moving was unacceptable then, and it's unacceptable now.
Dr. Gigi, you want to say something?
Yeah, I'd like to speak about sort of insurance, but also education of clinicians, because there are different recommendations. And I'll use the example of prostate cancer. They, said, well, the prostate cancer blood test that is available is not that reliable. And so all of a sudden, well, we're not going to do that. Well, guess what happened to Black men? Prostate cancer rates started to go up because physicians or clinicians were not checking it. And so it is with Black women. First of all, I'm a general internist. If you don't ask the questions about family history, you're not going to see what is needed in terms of the type of test that you need. If somebody's got a family history of breast cancer and a sister or mother, or it depends on how many relatives have it, or ovarian cancer family history, a screening mammogram is not adequate. That's just 2 views. You need a diagnostic mammogram with 4 views, and you might also need an ultrasound and an MRI. So, options like that, and where you're being treated like a cookie cutter, and oh no, you don't need it, or no, that's too aggressive, tells you that you really need to find another family medicine doctor, another internist, another whomever that can actually understand what the differences are in terms of Black women, Black people versus white counterparts, and not looking at you as part of a population, but as an individual.
Yeah, thank you so much, Dr. Gigi, because I was going to bring up Know Your Her story. There's some research that came out from the Ad Council a couple of years ago that said 92% of Black women are aware of breast cancer. They know about it, right? 25% talk about it. 25% talk about it. Only 17% act on the risk. And as Black people, we don't talk about health until somebody either dies or is dying, right? We don't talk about it at the kitchen table. We don't talk about it until somebody's really sick. Grandma Pookie has the sugar. And so we have to bring these conversations to our young women, to our children, to our teenagers, to our college students. We need to make sure that we're having conversations way before you even think about getting breast cancer or any disease. We need to do a better job with our families, talking about who died of what. Like, what's your family health tree? Who had disease? Who had high blood pressure? And put these conversations in everybody's space. Talk about at Thanksgiving dinner, talk about at Christmas dinner, but make people talk about it so we know. Like Mo went for years without knowing how her mom died. My mom didn't think about a great aunt that died of breast cancer at 42 till I was sick.
And how many family reunions, Ricky? How many T-shirts did we make? Uncle so-and-so married Aunt so-and-so. And it's easy to just put a little CRC, colorectal cancer, PR, prostate. We can include that information. And we as a community need to take away the shame and the stigma of having cancer. Because guess what? Absolutely. Every 8th woman, 1, 2, 3, 4, 5, 6, 7, 8, one of us. And if we have family history, might be 1 in 5.
Right.
And so there's no room for that shame anymore. But it was a shame because we didn't have the money. Like we grew up, we didn't talk about health, we didn't talk about money. You take some castor oil, some Robitussin, and don't ask for nothing if you go to the store, right? And God will make a way. And those were the things that we believed about how we, our generations. And it's not to knock those things, but it's to say that when we know better, we can do better, and we need to model those conversations.
Yeah,
I think we also, it points to the conversation about advocacy in our communities. When we see
Mhm.
signs about, in particular in certain zip codes where they're targeting things that may not be healthy in terms of fast food and alcohol, we can do ground rules work to change some of the messaging, counter messaging to more health, so it becomes normalized in the barbershop. We do find that when we have spaces like beauty shops and barbershops where we know that, and braid shops, if we put messaging in there about health and you're in there and you're spending at least one day a week there, it increases the information out there in the community. So there's places that we can put more information about breast cancer and health issues in the Black community. It also points to the need for more policy against us with insurance companies and the barriers and meeting the needs of a particular group. We were able to say for Black men, you will do it younger. And now for triple negative breast cancer policy work, we are asking that Black women get screened earlier.
Yes.
And that is important. I had my first mammogram at 28 because I knew my history with my grandmother. But that's me because I was also already in residency. So I was shuttled through the system very quickly and given an answer. And I didn't have to wait months like you, Lakia. But what I'm saying to you is that points to policies and advocacy. Said we will screen Black women earlier, and we just like we screened Black men earlier after we found increased rates. This data is showing that we do need an earlier prevention and earlier intervention model.
Mhm.
We do.
I would agree. You know, our breast density is 31% higher on average than white women. And if breast density is an independent risk factor for breast cancer, then knowing your breast density. When you get that letter in the mail that says the sensitivity of mammography is diminished for heterogeneously dense or greater breasts, and you're like, well, what does this mean? Does it mean my mammogram didn't work? No, it means you should be getting a 3D mammogram instead of a 2D mammogram. Those 9 slices through the breast, forwards and backwards, enables us to see more clearly. And if your breast density is more than 75% with no family history, you should still be getting ultrasound, right? And so it's really important for us to know those risk factors, like Dr. K said and Dr. Gigi said. You know, if we're not educated on what those are, we're not going to get the right screening. And let me just put a plug and say COVID has made everything worse. Screening rates have been down 90% compared to prior, and we're working our way back. But you know, if America gets a cold, then Black America gets what? Pneumonia, right? And so here we are now. We know that COVID is going to disproportionately affect our communities. We're seeing tumors just on the surgical side. Later stage, nipple discharge, palpable masses, lymph node involvement. Things are more progressed because people stayed home and they didn't know the difference between screening and diagnostic. Diagnostic means if you feel something, you get imaging. Do not pass go. I don't care what's going on outside. Get to an imaging center. Get to a biopsy. And we didn't do that.
Yeah, you got to check your breast, everybody. You got to know your breast. You got to
That's key.
know your body. Stand in front of the mirror, look at them, feel them. You know, my little fake
know them well
every day. You know, and you got to know your body because you are going to be your best advocate. So we're kind of running out of time, you guys. It goes by so fast. And we have a lot of questions in the comments on Facebook. So I think we should all go back and try to answer these questions for people. You guys keep it after the episode. But also, you know, and also let's put in where people can reach out to you real quickly. But I'm going to do a quick summary and then we'll do that. I think that what we talked about today is, guess what? Black breast cancer is a different disease. It deserves better, different attention. And I don't want anybody to die of breast cancer, but we should at least have mortality rate parity with white women. It shouldn't be a 41% higher mortality rate. Know her story. Talk to your mama. Talk to your grandma. Talk to your daughters. Do it for your daughters, granddaughters. Talk about it. Put it on the table, right? And then get the right medical team. If you don't feel like you're getting the care that you should, get another doctor. Or call us. We'll help you find one. But make sure you're comfortable and you trust the team that's working on your body and your cancer, your disease, whatever your disease is, right? Just even being healthy, right? And then you are your best cheerleader. You are your best advocate. Lakia, you said it best. I know my body better than anybody. Put yourself, you know, ask the questions, demand more time. Say, hold on, don't leave the room yet. I'm not done. I got more questions for you. And do what you got to do, advocate for yourself. And lastly, we can't advance the science of breast cancer for Black women enough. We can't. We have to participate in clinical trials. We have to be a TAMI. We have to find the next Herceptin. We have to find the drugs that we need for our bodies. And I want that that pill bottle that says this drug is made for Black women. That's what I want in research. And so we have to make that happen. We're not going to get it unless we do our own, do research and participate in trials. So everybody quickly. So Dr. Gigi, how do they find you?
Go to the Rodham Institute. Just Google the Rodham Institute. And we sign up for our newsletter, and my email is there.
Great. Dr. Kendra.
Museum of Health and Wellness. We have a Facebook, Museum of Health and Wellness.
Great. Dr. Mo.
I'm Dr. Monique Gary on all social media outlets. Dr. Monique Gary.
Reverend Tammy.
Just Google Carrie's Touch, CARRIE''S TOUCH.
Great. And Lakia.
I'm on Facebook, Lakia Belcher. You can find me on Instagram, Queen Belchy. Go to Touch. You can find me there too.
Yeah. touchbbca.org, Ricky at touchbbca.org. We're always here. We're on every Wednesday night at 6 o'clock on the Doctor is In Eastern Time. You can watch our videos and come talk to us, and we'll answer anytime, any day of the night, text, call, whatever. So just reach out. Thank you so much. Thank you for letting us do this. Thank you for the session. Everybody be blessed, stay safe and healthy.
Thank you
so much.
Bye-bye.
Bye.